board of the George Eliot and our final board before the Christmas period. We've had a very busy morning as a board. We've had a really great presentation from junior doctors and those involved in helping them during the COVID period. So real thanks to Aman, Hope, Roxy, Rosie and Joe who joined us. And then we've had sessions on the way things are looking given the developments in integrated care and other aspects of the way the develop, and Glenn will pick up on those later, as well as an update on how we are doing in terms of our journey in the development of the culture of the George Eliot, which Gertie led. So a pretty full board today, so I'll get things going at a reasonable pace. But thank you for members of the public who are either joining us now or will watch the video later. So we don't have any apologies of absence apart from David Elchingham, who's taking a well-deserved break. Any new declarations of interest from colleagues? Okie dokie, thank you. So the minutes of the last meeting, was everyone happy with the accuracy of those minutes? Please raise your hand if you were not. Thank you. So I'll duly sign those. Thank you, Ness, for taking them. So the action list, which is on page 22 of the pack, which we get on admin control, will have been sent to you. The first was a breakdown to be provided showing staff groups and ethnicity for cohorts 1 to 3 of the leadership programme. Can you tell me where we are with that, please? Stunned silence from the team.
It's a Gertie.
Gertie?
Action.
Sorry, I'm not able to open my papers on admin. I apologise, Chair. I'm having technical difficulties at the moment.
That's okay. Okay, Gertie, we'll come back to that.
So we just need to make sure, Russell, we include it in the next update to the board, which we can do.
Okay, thank you, Glenn.
Apologies, colleagues, I just can't get my papers.
That's okay, Gertie. The wonder of technology sometimes lets us down. We talked about a junior doctors forum to be invited to the future board workshop. We did that this morning. Really great. Thank you, Catherine. The next action point was a comprehensive report to be taken back to QAC on maternity services in the near future. That's planned, as I understand it, for December, Dowjit. So
yeah, that's correct, Chair. December. It's in progress.
So please, thank you. So please brief us at the start of February. Then the medical examiner to be invited to a future board workshop in conjunction with Dr. Foster update, and that's being planned. I think we're thinking about April of next year for that, Catherine, so please keep us briefed. Then we had the outcomes of the maternity acuity and dependency review to be brought back. That's planned for February, looking forward to that. And then an update on the STAR board expected to be included in the Chief Executive's report. Glenn gives us regular updates in his Chief Executive's report, but the conclusions of that STAR board should be available by the February board. And then on equality, diversity and inclusion, that to be added to a board workshop matrix for the new year. And that's in hand, I believe, Gertie as well.
Yeah, yes, it is. Thank you, Chair.
If we can just sort out the timing on your to be confirmed, that would be great. Then a revised terms of reference for the new FPC to come to the board in due course. We come back to that later, don't we, Sarah? Apologies, no, we don't. I'm getting my boards confused. I apologise for that. We'll come back to that in February. I'm a day early on that action point. And then Dowd to keep the board updated on progress with the children's safeguarding doctor role. Dowd, can you just update us on that, please?
I can indeed, Chair, thank you. So we were working with an external organisation to come with some form of arrangement where they would provide us with safeguarding. That was the last update that I provided to board. Unfortunately, that has not progressed. So we're still in the position where we don't have a safeguarding lead doctor. We are, however, pursuing something else, which is internal regarding a locum doctor who is interested in taking on that role. So we are looking at getting some support, further support from the CCG safeguarding doctor to see whether in combination we would be able to come up with something that will support us. What I'd like to assure the board is that in the meantime we're mitigating all these risks through the support that we are getting from the CCG doctor in the community, and also our own safeguarding leads within the organisation. But this is on the risk register, and it's one of our top 3 risks on the corporate risk register.
Okay, thank you, Dowager. But are you anxious about this area as an
every organisation requires to have a children's safeguarding doctor lead, and from a statutory point of view, we're not meeting that requirement. From a safety and a mitigation point of view, we have got mitigations in place, and we've got the support that we need to keep us safe in that regard. But it's the issue of not meeting the statutory requirement, and the key role and function of that doctor is to support other doctors in safeguarding leadership and also training, which we're able to do through our safeguarding leads at the moment.
Great, thank you for that clarification, Dowager. Then we've got the Finance Performance Committee getting an understanding of flow data in detail by ward. Stephen, where are we with that, please?
It would have been due to go to the FPA this month, but unfortunately with my absence, that didn't happen, so we're going to pick that up next month and that'll be complete. Okay,
thank you. Thank you, Steve. And then the next one is, and this is an old one, to new requirements, potential changes to the current FPPT arrangements to be brought back to future board for consideration. That's been deferred until further notice, so we'll keep that on the matters arising, as well as Dowager to come back to us on the SAF report on maternity. We'll come back to that one. That report has been released. Are there any matters arising that I've missed? Okie dokie. So Glenn, over to you. Please pull out the key points of your executive.
Okay, thank you. So I'll just pull out some headlines from the report, which hopefully everyone's had a chance to look at. I'll start with testing, and the good news is that we have started now the lateral flow testing, which is a straightforward kit that can be used at home, and we'll be testing all frontline staff twice a week. If those tests come back positive, because it's a less sensitive test than some of the more accurate tests, we will then go to the more accurate test, the PCR test. Staff will self-isolate in between. Just listening to the picture across the Midlands, because this is happening in all trusts, relatively low numbers of staff coming out positive from that, which is encouraging. And we have also now taken our delivery of the rapid testing equipment, which will obviously help us to manage beds over the winter. So then the next section is a extract from a talk I gave at the HSJ Providers Summit last week, which was discussing a range of things, but particularly the notion of which people have started to talk about COVID safe sites, which I suppose the corollary of which would be COVID unsafe sites. And I think that both phrases are misleading. What I explain here is that we need to maintain the very highest levels of infection prevention and control on all sites. And indeed, one of the biggest risks for us will be staff coming into hospital with COVID in an asymptomatic fashion, and the potential there of nosocomial infection, which is obviously something we talked about as a board before. And indeed, the highest individuals are at the highest rate of contagion in the stages before they start to show signs and symptoms. So that's one of the reasons why COVID-19 has been such a tricky disease to tackle. So I also then go on to say, as we manage this winter, the impact of long length of stay on our beds is just as big as COVID, actually. So the stats are there for the Midlands region. We've got a very good performance on this as a trust, and we need to ensure that that continues over this winter. I then turn to our staff, which obviously is the most important focus over this winter. And we talked a little bit about this at last month's board meeting, but one of the things that we will be now moving forward on is this Civility Saves Lives campaign. Board members will recall the presentation we had at the Three Boards meeting a few weeks back, where we heard from the national founder of that campaign, and included in my report here are some of the headline statistics of the impact of incivility in the workplace, which is a huge safety issue, as well as a huge productivity and recruitment and retention of staff issue. So we'll be using the pressures of this winter as a useful platform for us to reinforce those messages. And we've produced some posters and some material across the group that will support that. I then go on to the tricky issue of charging staff for car parking. There's been a series of letters that have been sent through to all chief executives across the NHS. I received a number of them, very standard emails concerned about this issue. In fact, I received one from Mickey Mouse, but others were from, I'm sure, genuine members of the community. I've set out here my response to those emails. I noticed the Coventry Telegraph have chosen to highlight the very final paragraph where I talk about this not being an issue of economic hardship for NHS staff. That wasn't the main point of this. The main point of this is that staff are very stressed at not being able to park, so we need to do something to control car parking. And despite talk of a national strategy and income to support it, that has not been launched yet across the NHS. So we're trying to ensure we've got adequate parking and that we are not subsidising car users with the income that we have to deliver patient care. There's then a great update from Medicine Directorate with a whole range of things that they've been doing to improve flow and safety, including working with some of their national leads on that, including Liz Sargent, who's excellent. And it goes on to talk about the great work of the endoscopy team also in there, and others. But I think the endoscopy situation is particularly notable as they have recovered their capacity up to a very significant level, and indeed have been helping University Hospitals Coventry and Warwickshire with that capacity as they've struggled somewhat in regaining all of their capacity post-COVID. So that's a really positive system working story. That's all I wanted to highlight. That's okay.
Thank you very much, Glenn. Very comprehensive. And members of the public may not be aware, but Glenn's been doing some great work at the national level to help the NHS find the right path forward, given the challenges that are ahead. So thank you, Glenn. Questions or perspectives to Glenn, please raise your hand. Otherwise, we'll move on. Okay, that's great, Glenn. Thank you very much. So we'll move on to the Restore, Recover and Reset programme update. Hack.
Thank you. So recovery, as Glenn has said, overall is going really well, but also the part of recovery is planning for winter and manage urgent care and flow. And you've already seen in Glenn's report all the good work that's gone on there, and that was part of the urgent care perfect month, and that's been going on over the last few weeks. We've also been planning and preparing for the vaccine, and also, as Glenn mentioned, around staff testing as well. So those have been the key pieces of work that have been going on as part of Restore, Recovery and Reset. But I really wanted to focus on our approach, which has very much been around improvement. And you've got some details in the report around the NHS Change Day called Fab Change 20. So we use that as a launch pad across the group, really, to mainstream our approach to continuous improvement. And as part of that, we've shared lots of improvement stories, so you can see them all listed within the report in some detail. But there's also a video that the comms team have helped to prepare, which is available on our YouTube channel, which shows staff talking about the improvement stories. I think that's a really powerful way of presenting the stories rather than just writing them down. So we're looking at working more with the comms team in terms of how we share our learning in more innovative ways going forward. And I would like to commend the comms team really and all the help that they've given in terms of preparing for the NHS Change Day, as well as all the support they're given in terms of getting improvement stories out there. So you can see those improvement stories are all linked back to trust objectives as well. So it's very much about how we go about delivering our objectives and focus on improvement. And as part of that, and part of the whole NHS Change Day, we also launched our approach to capture, sharing and learning, and that's where those videos come in. We've got a portal where everybody can share their stories as well. And building on with that, we're working, as I say, across the group. So this month we're also launching the group improvement network as well. So this is where we start to, in a more organised way, start to share learning across the group in terms of improvement stories. We're also working across place as well. So there's a place-based improvement group as well. And one of the innovations we're looking to take on from Wye Valley is Transformation Tuesday. So we're working on how we can make that work for us as well over here. So a lot of this is about how we reduce duplication, how we standardise an approach to improvement, and how we do improvement faster and further, and how we do that together, learning from each other, and as I say, avoid the duplicated learning. So that approach is beginning to work, and we've got another a dozen or so people going through the QSED training who'll all be doing an improvement project as part of their training as well. So I think we're seeing a gathering of momentum around improvement, and what I'll be looking to do over the next few months really for Restore, Recover and Reset actually to almost take a back seat really, because what we're doing is improvement ultimately, and that's how we're driving this forward. So it's not going to be about Restore, Recover, Reset anymore. It's simply about, well, I say simply, but actually it is what we've worked very hard towards, is focus on improvement and getting people engaged in improvement, and our clinical and operational staff on the front line leading on improvement and change. So that's hopefully the report sets that out, and that's the direction of travel. And I think we're in a good place to build on that as George Eliot, but also as a group. I'll leave it there and take any questions.
Hi, really great summary, thank you. It does worry me acronyms sometimes, the Group Improvement Network being GIN.
Yes, we have
members of the public. Yeah, don't want members of the public to get the wrong idea about what we do in our daily lives. Questions and perspectives, please raise your hand. Thank you. Rebecca?
Thanks, Chair. Thanks, Hack. I'd like to commend a solid report that really brings together a comprehensive range of improvement initiatives. My question is regarding the video consultation developments and this technology particularly. As this becomes the norm, can I take some form of assurance around our level of resilience to sustain this service?
Yep. So at the moment, we're in a position where the technology is available to all clinicians, and what we're doing is working with supporting clinicians to go live with that. And one of the discussions we've had recently is around how we set ourselves a standard about, well, what reach should we have in terms of remote consultations going forwards. But in terms of so some of this is around the logistics and the technology that we have to manage, but it's also, I think it's more about hearts and minds of clinicians, which is what's really going to make it work. We've got where clinicians are using it so far, it's working really well. The clinicians like it, and we get good feedback from patients as well. So in terms of sustainability, I don't see that as an issue at the moment. I think the key piece of work and the challenge really is about hearts and minds, and those clinicians who aren't using it so far, getting them to see the benefits and the value in doing this. And therapies have done a really fantastic job. It's used very widely across therapies and across the breast service at the moment, and we're rolling it out, as I say, over the next few months across all the other specialties in terms of getting clinicians actually using it.
Okay, thanks, Hack.
Jenny, did you want to add something? I noticed your hand went up.
Just to say that in the spirit of sort of building on the technology, we were also looking at doing some talking heads with some of the clinicians that have been using this, and also some of the patients that have been recipients of it, and to put it together a compilation to support encouraging people to use it where it's appropriate to do so as part of the package of rollout. So that's just one of the other things that is included in the project arrangements.
Okay, thank you, Jenny. And Glynis.
Thank you, Chair. Thanks, Hack. It was great to hear about all the improvement work that's going on, and it was particularly encouraging to hear about how it's been done in an integrated way across the system, not just about George Eliot working in isolation. And some of the projects where we are working together, like the high intensity users or the care homes, what I'm interested in is how we are capturing the impact of them and evaluating ones that don't have such easy measurable outcomes, such as reducing attendances at ED. And I'm thinking of things like the digital training in care homes, so that we understand what impact it's having and it's worth sustaining.
Yeah, so I think I'd have to say that there's more work to do, I think, on some of those where there aren't obvious measures. So we have use the QSA training, which does very much focus on the improvement methodology, very much does focus on measuring that improvement. But as you say, that it's not easy to measure everything that we're looking at, and particularly when you start looking at outcomes. So I think there is more work to do on that, and how we become more innovative in capturing all the impact that the improvements are having. At the moment, it is more focused on the traditional measures. I think that's a good point, something we need to build on.
Yeah, I think it is, as you say, Glynis, it is really heartening to hear the narrative and the focus and the aspiration to improve that Hack sort of summarised in his report. And I do think it's been one of the real successes of us joining the foundation group and Ali's work on quality and service improvement generally, and training staff to help them to have a rigorous approach to improvement. I think it's been one of the real successes for us as well as the foundation group. Colleagues, happy to move on? Okay, so we then are, thank you, Hack and Jenny, we're then into the receiving and noting of the maternity service risk management strategy. Daljit?
Yeah, so not very much to say on this. There's a requirement to review the strategy on an annual basis, which is what we do, and then bring it to board. There have been very few changes in the strategy. I think there's some minor changes in the terms of reference that are in the appendices, and some changes in titles. Otherwise, it's essentially the same as last year's.
Thank you very much, Daljit. Any questions or perspectives? Please raise your hand. Julie?
Thanks. Just a quick one, Daljit. Just in terms of this particular maternity risk register, how does that align with the wider corporate risk register, and particularly the oversight by the executive committee? Yeah,
so it does align, and the maternity, women's and children's, along with maternity, bit of the risk register comes to our executive risk committee every month, so we've got full oversight of it.
Okay, thanks.
Thank you, Julie. And Anil?
Thanks, Chair. My question was really linked to what Julie had said as well. I was looking at the diagram on page 62. I was hoping to see Executive Risk Management Committee there, but it doesn't show it there. Maybe that should be corrected.
Yeah, we can do that. Thank you.
Yeah, I think that would be good. Thanks, Anil and
thank
Julie.
You.
Just to provide that clarification. Any other questions? Okay, so with that one amend, Daljit, thank you for that. So we'll move on then to the report on safe nursing and midwifery staffing. Daljit?
Yeah, thank you very much, Chair. So the report that colleagues have is for our staffing levels during October, so it's retrospective. What I'd like to do is perhaps just update the board on some of the challenges we've had during this month. So overall, you can see from the report that we've made some good progress around recruitment. The challenge there is that many of these nurses will not start until January, as they are newly qualified nurses. And so we're continuing to mitigate those risks through reviewing our staffing levels 3 times a day, and also through bank, through the use of NHSP. So what I really want to bring to the board's attention is what is a really changing feast, if you like, over November during our COVID numbers. So a couple of weeks we did start to see quite an increase, and there were some challenges around staffing during that period, which were in specific areas such as ITU and in some of our positive areas, but also due to the fact that we were, like last time, we were continuing to deliver the services that we would usually deliver, like our electives. So that did add some additional challenge. What I can assure the board is that we did mitigate some of those risks. We were able to utilise some of the staff who had supported ITU in the previous COVID surge without having too much of implication on the delivery of services. One of the other elements around the ITU was that we were very aware that some of our external organisations and colleagues were experiencing high numbers in ITU. So George Eliot did reach out and offer some mutual aid to colleagues, which we talked about at board, and that was at the board workshop. That was particularly for Nottingham University hospitals, which I can say was really welcomed, and we had a lot of positive feedback from them as a result of that. Another area which you'll note in the board that we refer to where we've got really high vacancies is Victoria. Victoria, currently we're mitigating those staffing risks by not opening all those beds. There's only 21 beds open there at the moment. What we did do when our positive numbers went up was increase the number of beds that were open to 28. Again, we were able to mitigate some of those staffing risks from across the whole of the organisation. So I guess the key challenge is responding to the changes in the COVID numbers that we have, and we've got some good risk assessments in place that are enabling us to do that. Clearly, as we come out of lockdown over Christmas, I suspect that sometime in January, middle of January, may well be very busy for us, and we'll need to review our staffing levels again. The other element, I think, which Chief Executive Glenn has already referred to, is the impact of the lateral flow might have. What we've seen ourselves this week, we rolled it out in the middle of last week, is that we've had very small numbers that have tested positive. So that's not had the same the impact, that the worst case scenario impact that we would have thought it might. So it's positive in terms of that we are mitigating those staffing risks, but we are aware that those challenges will change from time to time.
Thank you, Dalgit. And I'm also conscious when you talk about members of staff being unwell, that some of the executive team has been unwell over the last few weeks as well. And members of the public should be aware that the executive team have worked incredibly hard throughout this period, and I know we'll continue to do so, but you have my enormous thanks for that. Glenn, do you want to make a point?
Yeah, I just wanted to pick up on the issue of critical care. As Dalgit said, we've been obviously we've been under pressure through COVID, and indeed the whole of the Midlands region has, and some of the pressure in other sites has been greater than ours. So we have been able to offer some support to them. But I think one of the key things about that, and we heard this earlier, didn't we, from the junior doctors, is that they feel safe and supported at George Eliot. And we get that discretionary effort from them as a consequence of that. So many of our staff are working extra shifts and extra hours to support their colleagues, to support our patients. So our approach has been to expand wherever we can capacity locally, rather than the centralisation of capacity. If you look at what happened with the Nightingale in London, their original strategy was to centralise critical care in a site, an unfamiliar site for many staff, and that didn't prove to be the best way to deliver that service. It was a net reduction in availability of staff as a consequence. So that's a discussion we've had with system partners, and we've been really clear, but very much supported by Swift colleagues as well, that the flexibility and the flexing and increasing of capacity on each of the acute sites is the way to manage those peak demands.
Thank you, Glenn. And Anil?
Thank you, Chair. Daljit, you mentioned about misalignment of data between ESR and reality for vacancy, and there is also a comment around cost centres not being aligned. Can you say a little bit more about what actions are being taken and when you expect that to be resolved?
Yeah, so we're working through that at the moment. There was some work done around this last year when we did if you recall, we did the establishment review, but there's still some further work to be done. I think that the essence here is to be really clear, and Gertie and I are having a conversation about this, about which data set we're using and what the implications of that data set is. So each data set in terms of where it comes from is the true picture, but it's actually what is that data representing. So the vacancies is come from, for example, from ESR. What we can see is that the ward establishments data, what finance have, for example, is slightly different. So we are working through that at the moment, and really hope to get that sorted within the next 3 to 6 months. But it is a big piece of work to do.
Thank you, Neil. Thank you. Just keeping the pace going. Gertie, did you want to add anything to that?
Yeah, it was just to give the board assurance that it is a piece of work that is ongoing at the moment, and that colleagues are working between finance, rostering and ESR to ensure that they're aligned. Obviously, because of the pressures with regards to COVID reporting, it's not necessarily going to take primary focus, but ideally within the next 6 months we will get to a point where we are reconciling ESR on the ledger and with rostering. I think the primary issue is that our nursing colleagues rely solely on the roster in the main, rather than actually the source of the truth, which is ESR, which is how we run and manage staff and run pay, and it's the source from which NHS EI would pull information out. So within the next 6 months we will get to a position where those are regularly aligned at the end of every month.
Thank you, Gertie. And a final question from Rebecca before we move on.
Thank you, Chair. To offer a perspective, at the end of your report, you've identified, Daljit, about the nursing associates that we've successfully been able to train, and now they're due to qualify. And I'd just like to commend the Trust for using such schemes and how we will hopefully use them in the future. Thank you.
Yeah, and absolutely really proud of the way that the ward establishments and the matrons have really engaged in that, and there's been so much. We managed to get a very socially distant celebration of the first lot that qualified, and the pride was immense, and they want to stay at George Eliot, and having conversations with some of them, they want to go on and do their registered general training as well. In fact, 2 are actually looking at it already, and I think that's really what we should be doing in terms of building our own workforce, and I think it's something to be really proud of.
I agree, absolutely. We had the same scheme at Wye Valley and it was an enormous success. And as you say, Daljit, the level of enthusiasm, motivation and loyalty to the Trust really shines through. Thank you very much. So we'll move on then to the CQC progress and preparedness update. Again, Daljit, with you.
Yeah, thank you very much. So the report, the position in terms of our CQC indicators is similar to last month. The key issue to raise with the board really is that we have put our formal monthly meetings on hold, but to provide assurance to, and that's due to the COVID numbers that were increasing, and to give the directorates time to focus on that. The assurance I'm providing to the board is that our governance team are continuing to get as much of the updates they can on a one-to-one individual basis, without putting too much pressure on the directors in relation to workload. The other thing to update the board about is that we had a conversation with the CQC this month, which was around our insights report, which overall was a very positive call. No major patient issues raised at all, and generally some positive comments about the progress that George Eliot is making. In terms of the future, and I think they've already got it on their website now, CQC are introducing a new approach called the transitional regulatory approach. approach, and the key lines of inquiry are now out on their website, so we'll be looking at them. This will involve a series of calls with the CQC where our directorate teams and our specialty service areas will also be at those calls, where they will go through standardised questions that they've got, so to provide assurance to the board that we've seen that today and that we are starting to prepare for those if required.
Great, and you'll no doubt give us an update at the next board on that, Daljit. Thank you. Any questions or perspectives on the progress and preparedness update on CQC? Anil?
Thank you, Chair. Yeah, excellent progress being made. But Daljit, as we discussed last time, especially in light of the external auditors having to do value for money audit, which is equivalent really to the use of resources, I think board should be cited on the actions and action plans on the outcome of the work that was done as a result of CQC on use of resources audit. So when do you think that will start coming to the board?
You're on mute, Daljit.
So I had a discussion with Glynis about this from the Quality Assurance Committee point of view, and I understand she was going to be discussing this with colleagues, so I'm going to look to Glynis for some support on this one.
Okay, well, shall we take it offline,
Yeah.
maybe? Would that be the best way to handle it? And
probably, yes.
We'll make sure everyone's briefed, Anil, if that's okay with you.
Thank you. Yeah.
Thank you.
Okay, so I'll give the opportunity for Glynis to chat offline. Okay, team, colleagues, happy to move on to the integrated performance report. So I was going to say Stephen, but then Hack has beautifully appeared on my screen. Hack.
Yes, it's me. Thank you. I'll just introduce the report and pull out some of the key points from the report. And I think the starting point really is for me to kind of mention what the key message is really, I think, in this report, that we are open for business and operating safely and at near normal activity levels, and patients should continue to access NHS services as required, including primary care, and use the new NHS 11 First service as well, which will help us enormously in terms of managing pressure on the emergency department, and it will also help to direct patients to the most appropriate service as well. A key focus over the last few months, as you know, has been on returning to pre-COVID activity levels, and in that respect, during October, we have performed really well. We've continued to increase the numbers of patients that we are operating on and seeing through outpatients. We are hitting the national trajectories on the whole and operating close to normal levels, as I say. In terms of context, we have managed to treat more patients than we planned to, despite the increasing pressures in terms of the number of COVID patients in the hospital, as well as steadily increasing sickness and absence levels amongst staff, with increasing numbers of staff being required to self-isolate. So, and we've got robust processes in place to support staff and managers through those processes. We have done all of this whilst remaining broadly within budget. The key overspend relates to non-tariff drugs, which we expect to be able to recover through additional income. We have cancelled very few operations despite the increasing pressures. However, these pressures have impacted performance against the A&E 4-hour target. Other parts of the region have been under greater pressure, and as a result, we've seen more ambulances arriving here. This has been exacerbated by the impact of intelligent conveying as well by the ambulance service, and often without prior notice. So we absolutely recognise our role in supporting the whole system and are committed to doing so. So we're working with the ambulance service and other partners to ensure that intelligent conveying works for all of us. And this will also help us to reduce delays in ambulance handovers, which we've seen a slight increase in over the last month as well. The ED department has also had to contend with the COVID outbreak amongst some staff as well, which is partly responsible for the small overspend against budgets that we've seen there in October, and we'll see that continuing into the first part of November as well when we see the November reports. So despite the numerous challenges, including increasing acuity, it's really pleasing to see that we have continued to perform well when compared against regional and national counterparts in terms of ED performance. The department is now much more resilient, and combined with the robust management of flow of patients through the hospital, in conjunction with partners, we are able to recover quickly from days when we see an influx of patients or experience difficulties in discharging patients in a timely manner. The increased levels of operating have enabled us to reduce the number of patients waiting over 18 weeks, and in particular, we've seen a significant reduction in the patients waiting over 52 weeks in most specialties. We do have a capacity shortfall in gynecology, and we're working through the options for that with a plan, if approved by Trust Management Board next week, to have additional capacity on stream for gynecology in January, and that'll help us to manage some of the long waiting patients there. We are doing well in restoring our diagnostic services and recovering to last year's activity levels, and as you've already heard from Glenn, doing really well on endoscopy performance, and that has meant that we are able to support some of the other providers, in particular the University Hospital. We've had some really good feedback from their clinical staff on the quality of our facilities, but also the support they've had from our staff when they've been on site using our endoscopy suite. Most modalities of imaging services are back to last year's levels of activity. We do have a capacity shortfall on MRI, which we're working through at the moment, and for both of those areas in terms of gynecology and MRI, where we have capacity shortfalls, we're conscious that we need to manage whatever additional capacity we put on stream within budget. So that's the balancing act we're going to have to manage between now and the end of the financial year as we manage competing priorities. Diagnosing and treating cancer patients is a key priority. The restoration and recovery of diagnostics and operating services has enabled us to diagnose and treat cancer patients more quickly, and we've seen our performance against the 62-day standard improve significantly, and we've only got a handful of patients now waiting over 104 days, and that's the best position we've been in for a number of years. So this isn't just a post-COVID thing. This is the best performance we've had for several years now in terms of the number of patients waiting over 104 days for their cancer treatment. So in these challenging times, we've maintained our focus on quality and safety as well. So during October, there were no instances of patients being infected with COVID whilst in hospital. The rate of patient falls in itself is not a cause for concern, but we have identified some avoidable falls, and I think that's a positive in the sense that we are focusing on improving here. We have already implemented actions to improve that, and there's also working with group colleagues to gain further insights into what else we can do to replicate any improvements that they've made as well. We also saw a slight deterioration in the monitoring of measures to recognise deteriorating patients. Again, we've taken actions very quickly to manage that, and we also have monthly ward assurance meetings that are monitoring all these metrics and making sure that we can pick up any issues and act very, very quickly. We've got good engagement in those meetings, and we're starting to see some of the impact of those meetings through some of the ward level metrics. So during the second wave, we have relaxed some of the requirements for appraisals and training, but essential clinical training is still continuing. And we continue to make good progress on recruitment, as you've already heard, with some staff still to commence in post over the next few months. And that will help us to manage through what we're expecting to be a difficult couple of months, and remain within budget as well in terms of managing our temporary staffing costs. And finally, we're forecasting a COVID capital spend of 2.3 million, which has been vital in supporting delivery of everything I've said so far, but we've not had our funding confirmed. So there is a risk around this, but I think a relatively small risk, because we're expecting capital to be spent nationally. So I'm hopeful that we will, through brokerage, get some capital funding for that. So I have covered the financial report in this as well, Chairman, so you'd be pleased to hear that and try to connect it all together. So in summary, recovery of activity levels is progressing really well, despite all the challenges. We're achieving some great levels of performance whilst maintaining quality and safety, and we're staying broadly within budget as well. So I think a good position to be in. I'll leave it there and take any questions.
Great summary, Hack. Thank you. Very clear. David would be proud of you. Glenn? Questions and perspectives?
Yeah, I think when we discussed a little bit of this morning in workshop, I think Stephen used the phrase quietly modest. I think that was the phrase he used, something like that. But I mean, there's a remarkable level of performance in all indicators there. So well done, team. A couple of things just to pull out for that, just to pick up the point that Hack made around capital. We have had some assurances from the regional finance director that should be sorted out. So we expect that to be resolved. There are a number of things you could point to there that are improving. I think the one that is particularly pleasing, we've got a winter assurance meeting for the Coventry and Warwickshire system on Thursday, and I'll be presenting on behalf of the system because I chair the A&E delivery board. But the year-on-year performance of the system is 5.5% better on the A&E standard than it was this time last year. But George Eliot's 12% better within that. And this is despite very similar demand patterns in terms of emergency admissions. So it's a really positive thing to see. But of course, if you do really well at turning around patients, then you end up with ambulances sometimes coming in your direction. So we'll be picking up the point about the intelligent conveyancing to see if that's operating fairly at the moment. But really good work from everyone.
Thank you, Glenn. And Simone.
Thank you, Chair. I agree with Glenn. You almost made that sound incredibly simple and easy, Hack, the way you described it, and I think it sort of underlies just how complex a picture you're dealing with, and the scale of improvement given the background is astonishing. So I just wanted to congratulate everybody. As you know, staff wellbeing remains at the top of our list of priorities, and I'd just like a bit more assurance and detail from either you or Gertie around the actions that we're taking to support staff who are off sick, but also the impact on staff who are carrying on working. Just a little bit more about that, please.
Thank you, Simone. Gertie, yeah.
Yes, Simone. So we've got a huge range of support options available for staff, those who are in work and obviously those who are away at the moment who aren't well. So we continue to try and offer a bespoke support for each individual member of staff who's off, depending on what their personal circumstances are and what their conditions are. And we work through that with the workforce team supporting managers so that they have got individual support for themselves.
Thank you, Gertie.
Huge amount of work going on from the HR team, and I think they should be congratulated for the work that they're undertaking.
Thank you, Simone. Any other questions on either the IPD or the finance report as Hack has covered both? Okay, thank you, Hack. So we'll move on then and welcoming Sue, who's joined us on the call for the Freedom to Speak Up report. Sue?
Hi. Thank you, Chair. So you'll see from the report that we had around about 20 cases during Q2, which is pretty static for the organisation. We usually get around about 20, so that's good. Obviously, how we've been getting feedback and how we've engaged with our staff has been significantly different during this quarter. There's been a lot more social media activity and a lot more Google Forms and interacting over Teams rather than face to face. We haven't been doing our usual walking around the organisation and picking up concerns. So I was quite pleased that our numbers remained quite steady. You'll know from this last quarter that we were mainly planning our Speak Up conference, which went really well at the end of October. So thank you to all of you guys that were involved with planning and presenting for that, including your lovely video messages, Glenn and Gertie and David. We also were busy doing all the board workshops with you guys, which you know because you were there in October. So although that will be reported in Q3's data, that was what we spent most of Q2 doing behind the scenes, was preparing our strategy and all of the work that we need to implement Speak Up going forward. Just draw your attention to a couple of the figures. So figure 1, we've put in, which is a new part of the report, which looks at length of time of cases. I was a little bit concerned that anecdotally we seem to take quite a long time to close down speak up cases, but actually when I've analysed the figures, the majority of them are concluded within that 4-week period. In fact, a lot of them seem to be within 72 hours, which was our target, so that's really good. The longer cases tend to be where we've got some HR activity going on around them. For example, if there's some performance management or some disciplinary procedure around individuals, that obviously slows down the process. Also, I find that the cases that go on for longer are the staff that need a lot more pastoral care and a lot more support around dealing with their issue, or they may be off poorly or out of the workplace for whatever reason. So those are the ones that you see that are tipping over 6-12 months. Figure 2 is the usual comparison of themes and trends. You will see, as usual, that behaviours, attitudes, leadership style are the hot contenders. And also we had a little bit of a spike around patient safety and staff safety concerns, the majority of which were around COVID issues. There was one patient safety that was around a standard operating procedure within a diagnostic team that was investigated externally from the trust, and we had assurance that there were no breaches and that actually everything was okay. The members of staff, although that element has been closed off, have still got concerns about leadership and management within their team, so that's ongoing, and that 2 of those are the grievances that you can see that are in this quarter's activity as well. A little bit from page 4, you'll see that we've mentioned the BAME network again. It's something that I've been supporting since my time at George Eliot, really. And the themes from there this quarter seem to be around staff feeling a little bit disengaged after doing things like the Stepping Up programme. They're not necessarily finding that the career opportunities are there for them to progress. Having explored that a little bit more with a couple of individuals, it might just be that they're not in a job role that allows for progression within their team, so they might have to look at the wider area. I'm not convinced that there's an element of being blocked from progress. I think it's just the actual career that they're in at the moment doesn't allow for natural progression. But obviously we'll keep an eye on those things. There's a lot of work going on around civility, around the being kind, all of the wellbeing initiatives, and of course we're really heavily involved in that because a lot of it ties in with that behaviours and that cultural element. Our hotspot areas remain outpatients, your domestics and estates teams, and then newer on this quarter's is some work in theatres. Myself and Dawn from Trade Union are just about to launch a project around theatres, actually, because back in 2013 there was a really big investigation into bullying culture, and we're just going to pick up that work. I know it's 7 years out of date now, but we're hearing the same sort of things again, so we're just going to pick up that work and rerun some of the questionnaires and surveys that we did back then and see what's changed, if anything, or what we can do to improve the situation there. Just had a really interesting conversation with the learning and development team and the apprenticeship team to see if we can support the domestic staff and the estates teams with more around their appraisals, around the compliance with training, and how we get the supervisors and things on that leadership management programme, because I think that will make a big difference to our casework. So other than that, I'd be happy to take questions.
Really comprehensive report. Thank you, Sue, and thank you for your hard work. Gertie, first of all.
Thank you, Chair. A couple of points from myself, and first of all, it's really a significant thanks to Sue as the Guardian. It's not an easy prospect continuing to maintain Speak Up activity and to link in with staff, particularly in that shift from face-to-face connections to moving to a virtual world. And I think, you know, the fact that we've maintained 20 cases in this quarter is something that we have to commend Sue and the hard work she's done. I can't but say that the conference at the end of October was anything other than a huge success. You know, she does mention in the report it's the first time we've done it across the foundation group, but it was a hugely positive event. It, you know, garnered an awful lot of conversation and generated a lot of chat on social media, and all colleagues who were involved were really delighted to have been part of it. and Sue worked really tirelessly to make it such a fantastic event. Sue's already picked up on the link between freedom to speak up and civility, and we are working with Sue in terms of her role as the Guardian, not just on the development of our behaviours, but also the work we're doing on civility saves lives. But Sue's also an active part of the work we're developing around a bullying and harassment action plan, because we do know from previous staff surveys that feedback from staff is that we do have an issue in terms of bullying and harassment. So there's some fantastic work there coming out of the Guardian's office. And then lastly was just to remind the board that we've had some support from the NHS charities, and we will be appointing a Guardian to work with Sue, a Deputy Guardian, in the new year, who will be working alongside Sue and focusing particularly on EDI activity. So whilst we've maintained and that reference to the EDI and staff with protected characteristics being less likely to speak up, that will give us additional support in terms of increasing, hopefully, the number of staff feeling enabled and having a voice. So thank you, Chair. That was all I wanted to add.
No, thank you very much, Gertie. Rebecca.
Thank you, Chair. Thanks, Sue. This is another brilliant example of the benefits of working across our group, and also the profile that you have at regional and national level, what we benefit from. My question is in regards to what methods are we currently utilising to evaluate the experience of staff who do speak up? So, for example, you know, do they find that you're easy to contact? You know, what's the extent of their satisfaction, etc. I wonder if you could give us a bit of a view about that. Thanks.
So everybody that speaks up gets a Google form to fill in afterwards. They don't have to do it, and obviously not everybody does, but most people do take the time to fill that in, and that asks them the questions that National ask us to include. So things like, given your experience, would you speak up again? And probably 99% of staff say yes. You do always get that one that isn't happy with the experience. Some of the comments that we've had back from there are, because of the Guardian, I feel heard. My experience with the Guardian has made an enormous difference. The Guardian made me feel happier and supported, even though my issue is still there. So sometimes those are the ones that are linked to behaviours and maybe relationships with colleagues. So yeah, on the whole, the feedback's really positive. I will include it in my next quarter's report because I've got some diagnostics to go now and some analytics.
Thank you.
Yeah, that's great. Thanks, Rebecca. I mean, it is really important for us to say as a board, without any sort of confusion, bullying and harassment in the workplace is totally and always unacceptable. Daljit?
Yeah, thank you, Chair. Thank you, Sue. Really mindful of the comment around our colleagues who attend in Stepping Up programme, and then an expectation, well, not expect, but their expectation that they would be then, you know, get other opportunities. And I guess I'm speaking from personal experience as much as anything, which is this view that if you send somebody who goes on a leadership program, that they're then going to get promoted into something. And I guess for me, it's about how we link all of that into a talent management strategy, where we're actively identifying staff for roles and also giving them the other opportunities, for example, through shadowing, through, you know, we've talked about reverse mentoring, through secondments, where they can actually gain those experiences in the other roles. I often do get concerned where people might raise their expectations because they've attended something like Stepping Up or any other leadership program, that they're then going to be immediately identified for another role, because that in itself is not going to solve that issue. And I speak personally of that, of somebody who's attended many types of these programs which are particularly aimed at individuals from those communities, which alone won't work unless we're looking at this in the whole and have a proper approach to talent management.
Absolutely, Daljit. I think we've lost Sue for technical reasons, unless I'm wrong. But if obviously we'll minute that point so she gets the point through the minutes, Daljit. But I think the point on talent management's being seen in a holistic, correct way is absolutely correct, and I know Gertie will be taking that forward. Glenn, is there anything you wanted to add?
No, I was just going to say that actually the talent management issue is one for every single exec, and for Gertie and I particularly, and David, to make sure that we're more proactive on it. we have strengthened the leadership structure across the organisation over the last year or so. We reflected on that this morning, but we need to make sure there's always an internal option for promotion when we have gaps at all levels. Doesn't mean they'll always get it, because we'll obviously also be attracting other people from elsewhere, but we need to ensure there's a pipeline internally as well.
Yeah, but it's also the flip side of bullying and harassment. A leader, a manager who encourages and takes risk on talent can have life-changing impacts on individuals. And it is, in my opinion, one of the most joyous things about being a leader is the way you can support and encourage others to fulfill their potential. Sue, I think, is really struggling with the technology. So by the minutes and through the ether, we'll thank Sue for her work. I know Gertie will pick up those points on talent. But if colleagues are happy, we'll move on to the annual schedule of board business and calendar of meetings. So Sarah, as ever, this is always a challenge getting this out. Thank you very much.
Well, thank you to
Over
to you. Thank you to Ness for putting it all together and helping me with the report. Thank you. So happy to take the report as read. There's just one further change since submitting the report to the board, which is on the public board schedule of business under the quality section. The medical staffing report, and we're proposing that that's also removed, as Gertie includes an update in her information through the integrated performance report. So other than that, happy to take any questions.
Thank you, Sarah. So any questions or perspectives with that one amendment that Sarah's just highlighted? Okay, so everyone happy to approve that forward calendar? Please raise your hands if you're not. Okie dokie, super, that's approved. So we'll move on then to subcommittee chairs update. The Quality Assurance Committee of the 26th of October, the report and the verbal update of yesterday's meeting. Glynis.
Thank you, Chair. Yes, as you say, we met yesterday and it was a very positive meeting, which I think is a reflection of all the hard work that the execs have put in over the last year to support staff and embed clinical governance across the organisation. Each meeting we have a different directorate comes along and presents information about the quality and safety of their services and their improvement plans. And yesterday we welcomed the medical directorate. And that's proving a really successful way of ensuring that we've got a real communication from board to board and strengthening our assurance that it is becoming embedded. So that was very positive. Still work to do, but making very good progress. Other matters just to raise is you'll be aware there's been a challenge with addressing the backlog of harm reviews for RTT and cancer. So although we're making very good progress on addressing the waiting times, there is still that backlog on harm reviews. There's been some work done on the process, which I have to say is very positive. It's going to make it much more efficient, but more importantly, it involves the patient in the harm review. So I think from a patient experience perspective is strong. What we did agree at QAC, though, is that we would extend the deadline to address the backlog to March 21, given that there is such a pressure on services at the moment, and we felt the focus should be on actually delivering the care rather than reviewing them. But nonetheless, we're capturing the learning and embedding it. Daljit's already mentioned the risk about the safeguarding doctor, so we had a discussion about that, and we'll continue to monitor that at QAC. And maternity services presented their new dashboard. And they've got the deep dive coming next month. And I do just want board to be aware, this isn't because we have particular concerns, but just because we're mindful there's been a big focus nationally on maternity and we want to take good assurance around our services. So a lot of work gone into the new dashboard, and it's certainly strengthened our assurance around maternity services. And finally, we received the updated and refreshed plan on mortality. It's a very robust plan. It's been done with the support of colleagues across the Foundation Trust. And so we'll continue to monitor that, but it was quite positive to see that our indicators are improving, and we're hoping that's going to be sustained and continue. I'm happy to take any questions.
Thank you, Glynis, and really delighted that yesterday was a good day.
Mm.
Questions or perspectives from Glynis or to Glynis? Okay, thank you very much, everyone involved in QUAC, and you for chairing it, Glynis. The Audit Committee report of the 24th of November. Julie?
Yeah, thanks very much, Chair. Like Glynis said before me, the Audit Committee was a really good committee, open and honest discussion with really good supportive challenge from all members of the committee. I will take the report as read. Just want to draw attention to the fact that we had discussion earlier around the duty of candour report can actually give confirmation that we're actually following compliance in that area. But also just wanted to draw to attention that we have raised the impact of the implications of the value for money for work by external audit and the impact that would have on workload for both finance and clinical staff. We've asked that to actually be escalated to consider whether it should actually take place in the coming year. And the other thing to note are the changes in the internal audit plan to minimise the impact on clinical staff during the current position. But what we've done there is agree that other audits will be brought forward that will add a similar value. Thank you.
Thank you very much, Julie. Any questions to Julie? Thank you, Julie. And then, Julie, over to you again on the Foundation Group Strategy Subcommittee of the 16th of November.
Yeah, again, assume that the report's read. I just want to draw attention to the board about the work that's progressing in terms of managed services, and particularly the work around procurement, which we know will actually ensure significant benefits to be captured. Thank
you, Julie. Any questions to Julie? Okie dokie. So we'll then just move on to the two sets of minutes for information only of the QUAC of the 26th of October. Any comments on those minutes? They've already been approved by the QUAC. Thank you. And then the Audit Committee of the 29th of September. Any comments on those? Okay, super. So any other business from colleagues? Please raise your hand if you've got any other business. Okay, so I think we're on to public questions. I think we've got three that I'm aware of, two from David and one from Natalie. Natalie, would you care to go first?
Thank you, Chair. I raised a couple of board meetings ago about outpatients getting back to normal, and I think you said that was on course. But over the weekend in the national media, it was about if you're suffering from glaucoma, the importance of attending clinics. And I know of two patients that go either annually or biannually that haven't had any contact from the hospital. Are they back on course?
Okay, thank you, Natalie. Stephen?
Yeah, so the clinics are back, getting back up and running. I mean, the one thing we are doing is looking at it in clinical priority and urgent order. The one thing I would do, Natalie, is if you want to contact me separately with those individual details, I'm more than happy to do a response to those particular individuals. But yes, the clinics are getting back up and running, but obviously we're doing it in a kind of clinical priority and urgent need first, and that's how it's working its way through. But if you want to get in touch with the individual details, I'm more than happy look at it and get back to you for those people.
Right, thank you very much.
Thank you, Stephen. Thank you, Natalie. And then David, over to you.
Thank you, Chair. I think I'm off mute. Could you just indicate if
you are?
Yes.
You are
right.
off mute, David?
Can I just first say to Hack what a brilliant job he did presenting that improvements performance report. I fully understood everything he put forward. Thank you, Hack. My question one is, with the significant increase in PPEs, majority of the product, of course, having a plastic content, can you assure the public that the George Eliot is disposing of the increased amount of material in a green and proper way?
Thank you. Stephen, do you want to address that for us?
Yeah, so I can assure you, David, there is an increase in the plastic waste because of the PPE response. However, we dispose of PPE through incineration, and incineration waste is treated as an alternative treatment, which effectively means it doesn't go to landfill and it generates renewable electricity. So I can confirm that through our PPE disposal, we're generating no landfill, and 100% of that waste is converted into energy.
Is there anything on the horizon about, Stephen, about recycling the plastics from PPEs, or is that just blue sky thinking?
Well, I think they see this as one of the most effective ways, because obviously it goes back into renewable energy. Obviously, if it changed, I'll let you know, David.
Thank you.
Glenn, is there anything you'd like to add?
Yeah, I mean, I don't know if you saw recently, well, David, there's some biodegradable latex gloves being trialled as well. So we do need to address this. Actually, it is one of the concerns about COVID that we have increased the amount of disposable items. But one thing that I expect to be in our objectives for the coming year is a bigger sustainability strategy for the organisation, where we'll take our role as an anchor organisation and do our bit for reducing the carbon footprint locally. So that's something that you will see at a board meeting soon.
Thank you on that, Glenn. That's reassuring. Question number 2 then, Chair, is I think it was touched on earlier that a large number of consultations are being done virtually. I just wondered if there was a percentage figure that you might be able to advise us on as to how many of our consultations now are done virtually.
Stephen?
Yeah, there's a national trajectory around this, David, which is 25% for new appointments to be done virtually and 60% follow-ups. We're actually a bit behind the curve on that, so we're averaging around 7 to 10% of new and 10 to 15% of follow-ups are done virtually. I think, like Hack said, we've got some key clinicians who are really keen on it and are really using it, and it's a slow spread across the organisation. So we've got a particular work stream looking at it. And I think it's a balance. So I think we have to take clinicians with us, hearts and minds. But those we do have some that are really keen on it and are really working with it. But I think we've got a bit of a way to go on it. So although it feels like we're doing a lot more than we were, relatively to other places, there's a lot of learning we can do. And I know that we're in contact with Y Valley, because I know they've done a lot of really good work on it. So we're trying to learn from there as well.
Thank you, Stephen. I guess, as you say, there's room for us to move forward, and certainly the comment that the doctors and the patients are quite at ease with virtual consultation, that is very positive.
Thank you, David, and thank you, Natalie, for your questions. Members of the public, if you want any questions answered, you're always very welcome to write or email me at the Trust, and I will ensure your questions are answered. I think that brings us to the close of the public board. I would just like to say to members of the public to wish you all a happy Christmas. Normally we're able to share a mince pie when we're together physically, and hopefully we'll be able to do that next year. But in the meantime, stay safe, and thank you very much. For our board colleagues, what we'll do is we'll have a 5-minute comfort break, and then we'll get back together again in 5 minutes for the confidential board, which is a